Welcome to the first quarter 2024 Indiana FADS education webinar on the documentation standards and retention of records.
This webinar is being sponsored by the Program Integrity Department. Your facilitators today are Patty Hansroth and myself, Leslie Slater.
This session will overview the following areas: the CMS Documentation Toolkit, Indiana's regulations for medical record retention, examples of service-specific requirements, common electronic medical record errors, and payment error rate measurement, and some key takeaways. At the end of this webinar, you should be able to navigate the CMS Documentation Toolkit website, review key Indiana regulations, discuss service-specific documentation requirements, highlight the challenges of electronic medical records, and understand common errors and way to prevent them. Patty, can you walk us through the CMS Documentation Toolkit, please?
Thanks, Leslie. Just to set the stage, let's briefly touch upon Medicaid and Medicare. Each state administers its own Medicaid program within broad federal guidelines. While states have a significant flexibility in administering their Medicaid program, CMS oversees the Medicaid program at the federal level and sets the minimum requirements. We can see an example of this with medical record documentation and retention of records. So let's go ahead and first talk about the federal guidance for both of these areas by accessing the CMS Documentation Toolkit webpage. Lucky for us, CMS has created the Documentation Matters Toolkit with helpful information that can be leveraged by providers. This webpage was developed to assist providers with tools and references for medical record documentation practices. As you can see, there are hyperlinks on this page that link to either a PDF document or handout, and there's also an embedded video. So if we go over these multiple PDFs, the first one is specific for medical professionals. The second is a fact sheet for behavioral health practitioners, and the third is for medical office staff. This fourth PDF is super helpful as it lists multiple resources that providers can leverage, again, for more information. As mentioned, it also includes on this page an educational video, which is about 91 minutes. CMS has also provided 2 associated PDFs that go along with the video. One is a deck that follows the video, and the second is a case study that is discussed in the video. The last 2 PDFs are for specifically health records. So if we go ahead and we open up the fact sheet, what we'll see is a total of 6 pages. It starts off with a brief introduction, then it goes over the benefits of the health records, words of caution for electronic medical records, some information on reform, conclusion, and then again, a number of great references. We recommend that you spend some time on this page and access these guidelines from CMS. We will now review Indiana's regulations. As mentioned, participating medical professionals must know and abide by both federal guidelines and the specific rules for each state where they practice. As such, Indiana has state-specific regulations for both medical record retention and documentation requirements. So let's first talk a little bit about Indiana's regulations for medical record retention. Record retention is equally as important as how the service is documented. It is recognized that although the process of retention for either paper records and electronic medical records are different, the retention guidelines are the same. So what are the most asked questions we hear regarding medical record retention? Question 1. As a provider, how long must I maintain records? The answer is that Indiana Health Coverage Program states that providers must maintain medical and other records of services provided to IHCP members for a period of 7 years from the date of service. The second question we hear is, am I required to retain records when I'm no longer a Medicaid provider? The answer is yes. Providers still must follow the standard for retention of records, which is 7 years from the date of service. Another question we hear, is retaining a copy of the claim form sufficient? And the answer is no. A claim form is not sufficient documentation. Providers must maintain medical records that are independent of claims for reimbursement purposes. As far as the content within the medical records, both the federal and Indiana guidelines state that the records must fully disclose and document the services provided. Also, the documentation for these services must occur at the time these services were provided to the member and must be documented prior to when the claim was submitted. Something to keep in mind. The coordination of services for members who have multiple medical conditions that are managed by more than one provider can only be successfully achieved when these services are documented accurately, completely, and in a timely manner. At a minimum, each of these listed components should be included in the medical record, regardless if the record is an electronic record or a paper record. Let's highlight some of these medical record regulations. Number 1, identity of the individual to whom the service was rendered must be documented on each page of the record. We will talk a bit more about this issue and specifically as it applies to printing PDF documents from an electronic medical record. Number 3, identification of a provider employee rendering the service, including dated signature or initials and their position. In a doctor's office, this could be the nurse who documents the patient's vitals and weight. Number 6, a description of the service that was rendered. This would include both the detail of the service provided and start and end time of that same service. Number 7, documentation of the location of the service provided. We have created a handout that goes over each of these bullets that will be made available on the Provider Education webpage for Indiana Medicaid providers. I'm now going to hand it over to Leslie to review service-specific requirements and provide some examples.
Thank you, Patty. Based on the services being rendered, the documentation requirements may vary. Let's review some examples. On the Indiana Medicaid IHCP website, under the Provider Reference tab, there are resources to find service and provider-specific program reference modules and bulletins. You can access the Provider Reference module by selecting the IHCP Provider Reference Module link. This page provides you with a primary reference for billing and reimbursement guidance for providers conducting business with the IHCP. Modules include instructions for submitting IHCP claims and prior authorization requests, as well as other topics. If you would like to review all of the resources related to service and providers, select the Service and Provider Specific Modules link. You will find a library of documents related to that topic. It is critically important to review both the provider reference modules and the bulletins on a regular basis. The IHCP Bulletins page provides an official notice of new and revised policies, changes and reminders related to coverage, billing, and claim processing, program updates, information about special initiatives, provider education opportunities, and official notice of changes to claim processing and billing requirements and procedures. Bulletins are issued on an as-needed basis and typically are published on Tuesdays and Thursdays. An example of a program-specific IHCP reference is for home health services. Within this policy, it defines the documentation that is required when rendering and billing for this service. These elements will be important for both providing and communicating the clinical care of the patient, but also to support medical necessity and claim processing. If you receive an audit notification, it would be important to include the following: the initial face-to-face clinical visit that prompted the start of the home health services, the referring provider's home health service order, the written plan of treatment with the provider's signature and date, the visit note for the date of service or services being audited, which must include both the provider's signature and date, as well as the patient or guardian's signature and date to validate services were received. The visit notes should clearly document the service provided, or in some cases, why the service was not provided, and the time spent. The start and end times to justify the number of units billed. We recognize since COVID, telehealth services has become a more common practice in the delivery of care. The documentation standards are the same as an in-person visit with some additional nuances, such as the patient's consent for receiving a service through telehealth is required. The consent may be given by electronic signature or verbally. If a verbal consent is obtained, this needs to be documented in the record, including the date, time, and who gave the consent, such as the patient or patient representative. In addition, where the provider and the patient are located should be documented. Is the provider in a clinic or at home? Where is the patient? Home or in skilled nursing facility, etc. The note should also specify if the visit was conducted by audio only or as an audio-visual encounter. For time-based coding, it is required to document the start and end time for total time spent. It is standard practice to document who was present during the visit, the patient, the guardian, or a caregiver, etc. Documenting time is not only important for telehealth visits, but also for many different types of patient encounters, such as psychotherapy visits, personal care visits, and some E&M assignments. Many of the time-based codes are billed in 15-minute units, but not all. There are codes that are 1 unit may equal 60 minutes. Be sure to follow the coding guidelines for assigning codes and the number of units. The documentation has to support the units being billed. The time must be documented within the provider's medical record documentation. This can be documented with a start and stop time or as a total time based on the service being rendered. Orders are critical for communicating the provider's request for additional testing, procedures, and activities. All orders should be signed and dated promptly by the ordering provider. However, there are some specific nuances that are allowed for clinical diagnostic tests. If an order for a lab test is obtained by the laboratory that is not signed, documentation from the patient's record needs to be provided to support the petitioner's intent to order the test. This documentation could be an office visit note indicating that a specific test will be ordered and the provider signs and dates the visit note. I will now turn it back to Patty to review some of the documentation pitfalls within the EMR.
Many providers have transitioned to electronic records, or EHRs. It's been recognized that electronic records can be an asset in meeting proper documentation goals. While EHRs can streamline documentation, it can also pose some challenges for providers. So let's go ahead and talk a bit more about these challenges. When Leslie and I perform electronic medical record reviews, we see several issues that generate problems that can potentially lead to denials. This is because they do not meet documentation requirements. The most common error that we see is identification of the patient is missing from the records. So what do we mean by that? Although the patient's name, date of birth, and medical record are found on the first page of the record, these same elements are missing from the subsequent PDF pages that are printed directly from the electronic medical record. Without this information, we simply are not able to authenticate that the medical record printed from the EHR is for the same member. Another issue we often find is specific to the electronic signatures for services provided. As we know, in order for the signature to be deemed acceptable, it must include all of the required elements, including provider name, title, credentials, and the date and time of the signature or electronic authentication. The third issue we find in electronic medical records is the use of the copy forward function, also known as cloning. This occurs when a provider copies the same text from a previous date of service or copying the same text for different patients. The type of documentation errors that we find in medical record reviews usually fall into one or more of these buckets. So let's go ahead and review some examples of errors in documentation. Missing documentation. An example of this is when we request an office note for May 1st, but the provider only submitted an office visit note for March 1st. Illegible documentation. For instance, we were asked to review office notes from an eye doctor. Upon review of these office notes, it could not be determined what was done or not done during the visit because the handwriting of the doctor was simply impossible to read. Insufficient documentation. As an example, a child is evaluated for a cough by a pediatrician. The highest evaluation and management code was submitted for payment, but the office visit note lacked the detail to support this code. Non-compliance with state or federal regulations. This issue comes up when Leslie and I review records for home care services. We often find that although there is a signed certification from the physician, there is missing a plan of care, which we all know is a requirement. No proof of delivery. We see this type of error with durable medical equipment. An example would be oxygen is delivered to a member's home, but there is not a signed delivery slip in the record to confirm that this equipment was received by either the patient or the designee for the patient. No prior authorization. An example of this is when physical or occupational therapy services were provided to a member, but there wasn't a prior authorization obtained. Incorrect coding. We see this issue come up with the misuse of modifiers for behavioral health services. These modifiers are critical in identifying the qualifications of a mid-level practitioner or provider. If these modifiers are not used as intended, overpayments are likely to be identified. Missing or incorrect date of service. An example for this is if a lab test was ordered by a physician on April 1st and the test was done on May 1st, the claim should reflect the date the test was done, or May 1st, and not the date the test was ordered, which was April 1st. Incorrect units. We see this error with billing of personal care services. When the medical record reflects a personal care assistant provided 2 hours of service or 8 units, but the claim shows the billing of 4 hours or 16 units. Lack of medical necessity. This documentation issue may occur when physical therapy services are provided to a member in the home. Upon review of the medical record, we find that the member is not homebound, he walks independently, and drives his wife to doctor visits. Duplicate billing. As an example, if a glucose test was completed in an office setting and both the doctor and the nurse document it, the biller may issue 2 separate bills for the same service. As discussed, the Indiana Health Coverage Program has identified both medical record documentation and retention as key components of their program. As listed below, documentation and the retention of medical records promote effective coordination of care, it supports medical necessity, and validates services billed. It also can protect providers against potential litigation. And lastly, it supports prepayment and post-payment reviews and audits. Next, I'm going to hand it over to Leslie to speak about payment error rate measurement, or PERM.
PERM audits are audits that are conducted by CMS on a 3-year rotational basis for the state Medicaid and CHIP programs.
In 2021, the Program Integrity Unit of OMPP discovered multiple errors that stemmed directly from inadequate retention of provider documents as revealed by the PERM audits. The question we hear a lot is, what were some of the other audit findings and how, as a provider, can we help reduce the errors?
Patty, thank you for asking for more specifics around this issue. The results of the PERM audits are the reflection of the provider community's record retention and documentation standards for the Medicaid and CHIP populations. If records are requested from the providers in response to a PERM audit, are not received, or do not support the services provided, the Indiana State Medicaid program has to pay back the federal component of the payments. This ultimately impacts the monies available to service the Indiana Medicaid and CHIP patients. It is important for the providers to maintain complete and accurate medical records per the IHCP policies and regulations. In summary, there are several key takeaways. Complete and timely documentation is important for both clinical care and to justify billed services. It's important to utilize the IHC provider websites for updated policies, banners, and bulletins. Electronic signatures require provider name, title, and/or credentials, date and time of electronic authentication. Time-based codes require start and stop times or a total time documented. On this slide, you will find additional references associated with this topic. Additional training courses are available on the Program Integrity Provider Education Training website. Thank you for attending this session. If you have questions, please email the Program Integrity email address listed here.